Live. Well, good evening, everyone. And thank you for joining us for the 28th Annual Flanigan Lecture event. I'm John Carney, President and CEO of the Center for Practical Bioethics, and we are delighted to have this event finally live after 2 years of totally remote. And we're doing a hybrid event tonight. And I want to congratulate the university, KCU, for doing that. I don't think we would ever be successful in pulling off a hybrid event. I think they're more than twice as hard as doing one either remotely or live. So thank you very much for your guys' support. And we're delighted to be with you this evening here at KCU. This is the 28th year, as I mentioned, to gather to honor one of the center's most treasured and wonderful mentors that we've ever had in our history. And Sister Rosemary this year, for whom this lecture is named, is celebrating her 96th birthday. And for all of her adult life, Sister Rosemary has demonstrated her vocational commitment to ethics and education and a passion for justice. As a teaching woman religious, Sister Rosemary invested her life in succeeding generations. She always taught students and was a mentor to all of them. She taught at Avila and Rockhurst universities and also here at KCU as an adjunct. Professor Flanigan prepared thousands of students to think more clearly about doing ethics. And Sister Rosemary will remind you, we do ethics with that little finger that she'll point right at you. Many of her students went on to become nursing professionals. And while Sister Rosemary has relocated this past year, she and Patty finally made the switch and moved to St. Louis. We know that she is watching this evening, and if not yet right now, she'll be able to see this in record sessions. And she is deeply concerned about not only the vocational crisis for nursing professions, but for all those who give their lives to people in need and those in need of care. So we want to thank you, Sister Rosemary, for your life of service, for your 96 years. Wish you a good number more. I'm not going to put a number on that. All I know is that if you hit 90, your chance of living to 100 are better than mine. So good luck to Sister Rosemary. We would like to invite you to make a gift in her honor, perhaps $96. I'll go online to Practical Bioethics. We'll be happy to take your donation there. And you can put a little note in there and we'll be happy to send it to Sister Rosemary in St. Louis. And now it's my pleasure to turn over the microphone to Dr. Terry Rozelle, who serves as the Rosemary Flanigan Chair at the Center for Practical Bioethics. Terry.
Thank you, John. It is my privilege to welcome and introduce our speaker and panelists for the evening. This event is titled, as you know, America's Nursing Crisis, What Should Be Done? And with us this evening is Dr. Karen Cox, who is the president of Chamberlain University, Dr. Maria Fox, who is the director of Advanced Practice Providers at the University of Kansas Health System. We have Arams Iboya, who is a critical care nurse, is someone who's actually taking care of patients and has done so for the last 20 years, also at University of Kansas Health System. Eva Karp is the Senior Vice President, Chief Clinical and Safety Officer with Oracle Cerner Corporation, also long affiliated with the Center for Practical Bioethics and the Board of Directors. Angie Knexted has a lot of titles, and I won't read them all, but Angie is with the Office of Equity and Diversity and also Pediatric Bioethics Center at Children's Mercy here in Kansas City. Joy Roberts is the interim dean, right here, interim dean at UMKC School of Nursing, also has a law degree to go along with her nursing background. Carol Thomas is the Vice President of Clinical Operations at KC Care Health Center. Did I get you all? I did. Very good. We have a lot of panelists because I needed the diversity that each of them bring. And we are covering a lot of ground with this highly qualified panel. There's the list. Oh, it's going back. Our session is going to begin with a brief presentation by Dr. Karen Cox, who is not with us in the room, but will be joining us virtually. And Dr. Cox will speak to us about her perspective on America's nursing crisis as the head of America's largest school of nursing, Chamberlain University. But before Karen comes to speak with us, I want to welcome to the microphone Dr. David Sine and Dr. Ed O'Connor. Dr. Sine is chair of the Department of Bioethics here at KCU. He's published on the importance of interpersonal communications between nurses and physicians. Dr. O'Connor is KCU's provost and vice president for academic research and student affairs. Ed also serves on the board of the Center for Practical Bioethics.
Well, thank you, Dr. Rozelle. On behalf of Kansas City University, I'd like to welcome all of you, our panelists, our friends here on our Kansas City campus, and all of those who are joining us virtually from afar. Welcome. As a host, I get to talk a little bit about us, right? So I'm going to tell you a little bit about Kansas City University. Founded in 1916, one of the 5 original osteopathic medical schools in the country. And our first graduate was actually a female, Mamie Johnston, DO, who actually taught here for 47 years. Unusual in 1916 to have your first female graduate. Those of you may know this, our administration building was the original site of Children's Mercy Hospital, built in 1916, same time. Started by Catherine Berry, a surgeon, and her sister Alice Berry, a dentist. As you're walking across campus, you'll see a conference room up on the right with all a lot of glass. That was the original operating room, placed at the top level of the hospital at the time to allow the most light in 1916. And on top of that building is also a patio, open air patio that was used to treat patients with tuberculosis, right? We'd roll them out to get some fresh air back then. Kansas City University moved to the site in around 1980. Children's Mercy left in 1970 to move to their Hospital Hill location. And in 1980, Kansas City University moved here. We've grown to become the 6th largest medical school in the country. Let me tell you that again. 6th largest medical school in the country, largest provider of physicians in Missouri, and 2nd largest in Kansas. Why is this important? I'll tell you why. We are, I believe, and Dr. Sine will correct me if I'm wrong, we are the only medical school in the country to teach 3 full courses in bioethics. Let me say that one again. Is that right? Okay. Imagine this. We're the only medical school in the country to teach classes, 3 of them, full classes, in bioethics. Seems obvious to all of us in this room and on our Zoom friends. What? We don't teach physicians about bioethics? Right? We do here at Kansas City University. We have over 12,000 graduates, 9,000 practicing alumni. 65% or about 2/3 of our physicians practice in primary care and 25% in rural care, the biggest need in the country, right? That's where our need is. And more importantly, our students do about 15,000 hours of community service annually in the Kansas City area and then now in Joplin. So let me just say quickly, I'm a neuroscientist by training. So, right, you know, the hard scientist, as we like to call it. But I'm here in front of this group and our friends on Zoom to openly admit I'm a closet humanist, right? And proud to be a new member of the board of the Center for Practical Bioethics. I believe the study in humanities is needed if we are to succeed in articulating relevant, historically informed, and culturally nuanced responses to the grand challenges of our time, which unfortunately, right now is a rather long list. Injustice, social unrest, health equity, environment, just to name a few. Kansas City University is proud to be partnered with the center to educate, converse, and debate with our future physicians and other healthcare professionals. This is impactful work. And tonight we are taking on one of those challenges, addressing the nursing crisis. I look forward to the conversations and the presentations. Again, to everyone, welcome to Kansas City University. And at this point, I'd like to turn the mic over to Dr. David Sine, chair of our bioethics program here at Kansas City University. Dr. Sine.
Thank you, Ed. I resisted the urge to leap to my feet as you were talking about the 3 courses that are embedded in the program. I wanted to leap up, and as any good Chicagoan who watches late night TV would say, but that's not all. So truly, there are these 3 embedded courses, and the students here all get them in their first, second, and third year. And as they progress from their first year to the third year, each of those ethics courses becomes more clinical in nature. You start out with your first one's very philosophy-based, and by the time you get to your third one, your third year, very clinical and case-based and taught by a clinician, not just a bioethicist. We've got an MD bioethicist who teaches that course for us. But that's not all. If in the middle of that first year, you decide as a student that you like bioethics so much, you have an option. You can raise your hand and say, I'm so fascinated by this, I'd like to get an additional degree in biomedical ethics. So we have a master's degree in biomedical ethics that you can get coincidental with your 4-year medical degree. We're very proud of that. And here's the good part. I think this is the only DO school in the country that offers a dual degree like that. That makes us very unique. And I routinely hear from students that say the reason I came to KCU is because of the opportunity to get a degree in biomedical ethics. They're great students, and we give them a lot of good information that truly makes them better physicians. Now, part of that degree and part of those 3 embedded courses is also focused on interprofessional education, which brings us to the nursing crisis. Because what we have found in numerous studies over the past few years is that the communication between the physician and nurses is a little imbalanced. If you ask the physician, what's the quality of the communication between you and the nursing staff? 85% of the physicians will say, it's really good, we're really tight, it's great. If you ask the nurses that same question, what do you think they say? Not so good, not so good. It's almost the opposite number. So we focus on interprofessional education. We focus on professionalism and speaking civilly to one another and communicating in ways that your message is clearly sent and clearly received. We learn a lot from other industries and how to do this, and we're very proud of these programs. I want to thank you all for allowing me to tell you a little bit about our dual degree program and our embedded 3 courses. We're obviously very proud of those, and we all should be. And of course, all of this is made possible by the great relationship we have with the Center for Practical Bioethics. I want to thank Terry Rozelle, who's standing behind me and backing me up as he has since my arrival here. Thank you, Terry. You made this all possible. And John, I think you are up next. Terry's up next.
Thank you, Dave.
Okay.
Thank you, Ed. And we're going to welcome Dr. Karen Cox right now, who will join us virtually.
Good evening, everyone. It's so great to be here with you. While I wish I was there in person, I'm glad to have the opportunity to participate in this evening event and with several of my friends and colleagues that are on the panel. And I want to just do a quick disclaimer about that nursing crisis, because I believe the nursing crisis is just a symptom of a larger issue, which is a financially unsustainable healthcare system focused heavily on illness and with limited view on wellness and prevention. But that's for another day. That's for another panel. But I just wanted to throw that out because sometimes I think it's seen as an issue in isolation. And so to just start with the nursing crisis, the nursing shortage, we've had shortages off and on throughout the years, but nothing like this. And it isn't a shortage of nurses. There's not a shortage of nurses in the US. There's a shortage of nurses willing and able to work in acute care settings. Now, before the pandemic, 60% of nurses worked in acute care in hospitals. And we know that's probably down under 50% right now. And so it's not as simple as educating, training new registered nurses. It's also looking at why they're not staying and working an entire career in acute care that many did until the last decade. And so when you think about that shortage and how few work in the hospital, the other thing that's interesting and different from other professions clinically is that they're within that 50+% who work in acute care, there are a lot of us, a lot of individual nurses who work in other positions, in leadership, in quality improvement, in risk management, in patient experience, you name it. It's the great thing about being a nurse. There's so many opportunities. But what we don't do as nurses in general, when we move to those roles, we don't stay clinically engaged or clinically relevant, which is very different than what our physician colleagues do as they move into other roles. So it takes great, talented, experienced nurses away from the bedside, away from where the majority of what nurses needs to do happens. And so like many other things during the pandemic, the shortage, the crisis was accelerated. But it didn't just start with the pandemic. The conditions that allowed it to get to this point were there before. They were there in terms of the base staffing that hospitals had, not necessarily being to the level that it needed to be to deal with peaks. It has been a job that is hard to do. I think when we started the whole notion of primary nursing years ago, we thought that nurses did everything the best. And that made sense. And it made sense at the time. At least I thought it did. But what we have now is a situation where patients in the hospital are so very sick. And the work itself, the physicality of it is not sustainable for an individual for many years at this point. And one thing that people don't like to talk about is some of that is because of the increased obesity in the US. If you think about getting somebody up out of bed and helping them walk who weighs 100 pounds more on average than they did 10 or 15 years ago, you can see over time what that does to somebody's body, not to mention the psychosocial aspect of the role and the critical decision-making components of the role. Nurses have increased the number of patients they're taking care of during the pandemic. And nursing in clinical care in hospitals, it suffers from what's called complexity compression. And that is where a professional has to take care of more than one client at a time. And so if you think about it, you probably don't go to a appointment with a lawyer and have them say, well, why don't you just sit in with this other client and I'll just talk to all of you together. That doesn't happen. The only profession that's related to this phenomenon is education K through 12. But even then you have what you believe are like-minded, prepared, same level of skill students. So it does make for very interesting, fast-paced, rewarding, but yet can be exhausting. And the other thing that happened during the pandemic that people don't fully think about is that the deaths that occurred, it wasn't just the number of the deaths being so high, but it was that many of the individuals were awake or alert or knew they were dying, and they didn't have their families there. And we quickly found out that families and caregivers for patients are the safety net for the nursing team, because they're there to add hands. They're there to notify you of changes. And they're there to be with patients who are at the most vulnerable time of life, the end of their life. And so that was particularly jarring, I think, for many nurses. A lot of nurses came from other areas. So, if you have somebody who works in OB, now suddenly faced with the acute care situation that's very different than their experience, it just multiplies the stress and the burnout. And I'm going to come back to burnout, but what's also interesting is the narrative about nursing in the press. The first half of the pandemic, the first year, was amazing. We have never, as nurses, seen that kind of publicity in the lay press, and it was good. Nurses were heroes. Nurses were giving. They were giving of themselves. They were working many hours. And that was great. And then about the time that the vaccine came out, and there were many people not taking the vaccine and many people still needing hospital care, nurses found themselves in a place that they don't ever want to be. And that is being resentful or angry with their patients. That's not who we are. You don't go into nursing or healthcare for that matter, if that's your perspective. But they felt like they're being asked to sacrifice, to work hard, to provide this care to people who, even when they're in the hospital, having bad disease, still remaining firm that they don't want the vaccine. And so over the last year and a half, the press has been more about the negative impact of the work environment for nurses, and really went a complete 180 from the original positive narrative. And the other thing that's happened in terms of the narrative was the case of Redonda Vaught, a nurse, and I'll talk about that in a minute. But before I go on, I think it's important that we realize that burnout is not an individual issue. It is an occupational one. So I get a little concerned when I hear people talking about, well, they just need to, have their nurses be more resilient, take better care of themselves, attend to their mental illness. And none of those are wrong, but that's implying that burnout is the sole responsibility of the nurse. And that really isn't the case. It's about the occupational environment a person finds themselves in. And so when you try approaches that on Maslow's hierarchy are up toward the top, when they're, living from shift to shift, working very hard in difficult conditions, it's not going to give the message or have the result that people would hope. One of the things about the environment that we have to address is the turnover in the first year. And I believe that's a result of two factors. The first factor is the environment itself. When you come in your first role, do you feel a sense of belonging? Are you onboarded in a very organized and methodical way? Is the staffing reasonable so that you can, as a new nurse, begin your profession or your practice? The second thing that I believe is a part of that is the fact that nurses don't always know what they're getting into. If you think about it, nurses are educated as generalists, which is a good thing, but they rarely get the opportunity to figure out where they're going to be the best fit. And so we think that is another issue, and I won't go into it, but Chamberlain received an A&F, American Nurses Foundation grant called Practice Ready Specialty focused on perioperative nurses. And in trying to figure out if we can match people, give them the experiences where they think they want to practice, that we can decrease the workload. So the research is underway, more to come on that. One of the most concerning things that I think we should all be aware of is that there are two age groups of nurses leaving the bedside. One group are 60 plus. Well, that's fine. It's time to retire. And I just mentioned how physically difficult the work is. So That's a group that has done their time, given to the profession, given to healthcare, and we expect that. But the second group are people in their 20s, and that's frightening on a couple of counts, not the least which that we base workforce projections going forward on the notion that these 20-year-olds will be here when they're 30 and 40 and 50 working in the profession and clinically. And so what that really means, it's not only are hospitals facing serious sustainability issues financially regarding costs of nursing over the last 2 years, the reality is that's going to be diminished somewhat because we aren't going to have enough direct care nurses without changing the model. The model that we currently have, it's already proven not to be effective and can have a very negative impact on patient safety. If people knew the average experience level of the nurses on the inpatient floor where they would be shocked, I think, to see how little experience there truly is. I have the privilege of talking to CNOs all over the country every week, and they're experimenting, trying different approaches. But most of those approaches mean that nurses become conductors and not the doers. They're conductor. They're not also the first chair of the flute and helping back up with the trombone. They have to be the conductor. And that means that they're going to have more patients than they're used to. And that is a different concept. And nurses have not been educated in that way. Some of the models use what they're calling virtualists. So nurses who are helping support people on the ground that are virtual. One really creative thing was a market where there's a fair amount of pharmacists graduated each year. They're using a nurse pharmacist team where they give the nurse 8 to 10 patients, and the pharmacist within their scope does everything related to the medication that they can. And people are trying different ways of supporting nurses when they are giving additional patients and just looking at the processes that surround them. But what I want to quickly talk about is as we think about how this shortage, how to get out of it, at least on the pipeline side, we have to attract a different demographic to nursing. The dependent, young, white, middle to upper middle class female has been who we relied on to become nurses. And that demographic has changed. And in addition, in the last year, over 60,000 qualified applicants were turned away from nursing programs. Now, there may be people who applied to 2 or 3, but nonetheless, that's a big number. And why is that? Why aren't schools adding more seats to the programs if there's a demand? Well, one, there's a lack of faculty, and there's also a real a cost associated with providing a BSN degree that's much more significant than other bachelor's degrees. But the other thing is that nursing programs are judged on their first time NCLEX pass rates, which is what gives you the ability to be a registered nurse. And that has been something that has been an issue for us quite a while. We know from studies that only about 30% of a person's ability to be successful once they're in a nursing program is about their academic ability. The rest is just about the social determinants of learning, the things that have happened in their life. And most nursing programs use the GPA as the way to sort out who they're going to bring in and who they're not. Because if you go down in the GPA, there's a worry that that's going to decrease the NCLEX pass rates. And we know we by doing that, decrease the opportunity to have a more diverse workforce. That limits the ability for people who've been in low resource high schools to participate and become nurses, and many of them desperately want to. And so the profession is still struggling with what's called implementing a holistic admission process, where we don't look just at GPA, but many other factors. And we also know that through the pandemic, we all know this, but the health disparities in this country are unconscionable. And to really get at that, we're going to have a situation where the profession reflects the demographics and the complexion and complexity of our population. So finally, the Redonda Vaught case, which was before the pandemic, she was criminally charged and convicted of negligent homicide for a medication error. And so this was before the pandemic. So now you have a situation where, from an ethical perspective, nurses are saying, if they are give me an assignment that's not, I don't think is reasonable or safe, am I, by saying I'll do it, saying I can do it, and if I make a mistake, I'm going to be criminally liable. So that's another way that staffing comes into play, just in terms of our ability to provide care. But as nurses and healthcare in general begin to focus on what I call continuing health, not a transactional health system, we will realize the full picture of the health that the citizens of this country can experience. And the health of the population, I believe, will improve for the better. So I'm still very hopeful. And with that, I'd like to turn it over back to Terry and the panel.
Thank you, Dr. Cox. You have given us a lot to ponder. And we'll have opportunity for the next 45 minutes or so to do that. With some opportunity for those of you who are virtual to place questions or comments in the chat. We won't be able to get to all of them likely, but we are monitoring the chat tonight and invite you to participate that way. And hopefully we can get to some of those questions specifically. Also, we have microphones that can wander through the audience here that's in the room. And if you have comments or questions for Dr. Cox or any of our panelists, we can get to that question as well. We are going to go to our panelists now, to Dr. Fox, Mr. Boya, Dr. Karp, Ms. Kneksted, Ms. Roberts, Ms. Thomas. And each of you will have opportunity to say something, but I'm wondering if any of you want to say something to Karen at this point in response to her comments. If so, pass the microphone to anyone who might want to respond. But go ahead.
Good evening, Karen. It's great to see you. The Redonda Vaught story has been striking across the country, has been a problem for nurses because they are in fear of criminal prosecution for doing something that actually the health system failed her. There were staffing issues, there were technology issues, there was the complexity compression that she was dealing with. She was a float nurse that went from one unit to radiology to ED to do a swallow test and back. And that is a lot for a clinician to put through and not make a mistake, as well as coaching and teaching a new nurse at the same time. So when we look at criminally prosecuting a nurse that probably was set up for failure, that was people, process, and technology, it is frightening, and clinicians want to flee and not practice anymore. So Karen, what do you suggest on how we provide a safer environment for clinicians to practice in so they're not in fear?
So thanks, Eva. Good to see you. I do believe that the fact that she did not get sentenced to prison was because of the efforts between the time she was convicted and the time she was sentenced. Because the outcry in a lot of times in healthcare, we're not aligned. So you have the hospital association, the medical association, nursing associations, quality and safety, insurers. This time it was fierce. Everyone came together, recognized what an impact this could have. So if nothing else, I think we got people's attention about why this is not the right thing to do in healthcare. But I think it's an effort that's being continued by organizations to really raise to the top level why it's important. I was so pleased when a number of hospitals, the CEO and the CNO sent out emails the next day and said, "We will have your back. You know, the just culture lives here." But that rings hollow because they don't have the authority that the prosecutors and the courts do. So I think we're going to have to continue the discussion about it in a pretty aggressive and rapid manner before this happens again with a prosecutor who or a court who's really out to prove a point for some reason. But it really, I felt it destroyed partially all that I'd worked on for 10 or for 20 years since the IOM report came out. The other thing is I would advise nurses, and I'd be interested in Joy's view on this, but if you're accepting something and you're concerned and you feel at risk, document that. Document it right to the person who you're working with, make sure you have copies and make it clear why you're concerned, but that you're doing it out of the best possible interest that you can provide for patients. But it's got all the professions. This was a nurse, but it doesn't have, nurses are higher risk because of the activity and numbers, but it's a serious threat.
Is this a congressional sort of a legislative fix that needs to be happening? Is there lobbying efforts going on that any of you are aware of at a federal level?
Is Joy getting ready to
Okay,
speak? I
there
know
we
it.
go.
Yeah,
Yeah,
the
I was
state
trying to
level.
figure out the microphone. Actually, there is not at the moment. This is something that happens at intervals where we will see cases where a registered nurse, and very typically it's that same synergy of um, being asked to work crazy hours because there's a shortage, being asked to work in a place that they are not normally working, being asked to utilize a technology system that is unreliable. A lot of times sleep deprivation comes in. And then the key is there is also a prosecutor who wants to make a name for themselves. And that happened in this case. It's happened in prior cases as well. You know, it is easy to say something should be done, or is there a legislative fix? There is the possibility of one. Fortunately, this doesn't happen really often, but it certainly has a chilling effect on nurses' willingness to work in high-risk areas, OB, ER, ICUs, where they're expected to be moving quickly and dealing with critically ill patients. And eventually, each state will really need to come up with some sort of measures for protecting people, or we won't have nurses and we won't have physicians, and that's not something that we can do without.
Anyone else have any response to what Karen presented, either on that case or some other?
Hi, and I would have to say as a bedside nurse that you always worried about that paradigm shift, right? So, how does this case affect the nurse community as a whole moving forward? And that's always a concern because, you think about after the conviction, as nurses, you have this sense of indictment and, towards honest reporting of errors. And so you can't have that, especially now moving forward. How does it affect nursing? Well, it can affect it in two ways. So the first being that hope that you are stuck in a culture where you are shame and blame of the individual is the focus, or we can focus on implementing safeguards and introducing better practices and strategies and introducing more safe, robust systems that minimize errors and promote patient safety. I personally, I hope that collectively we choose the latter.
So Arams, while you have the microphone, you are in the ICU,
Correct.
taking care of patients, working with a lot of other nurses throughout your hospital. Have you seen any impact specifically on yourself or the nurses you work with in the wake of the Redonda Vaught case down in Nashville? I mean, has that had any tangible impact on you or on those you work with?
Well, currently, it's hard to say. I would say at KU, we have I'm fortunate, especially in surgical ICU, we have a great system in place. We do encourage the nurses to report, honest error mistakes because medication error is an unintentional act. And that's the reason why you want to, instill that culture. Again, the patient is always the center of focus. You want to learn from every error, every mistake, so you can have better system, better safeguards in place to promote patient safety and well-being. But as of now, every unit that I've been to, I think the nurses are still very vigilant, working hard, promoting, patient safety, and just, doing the best they can. So.
We thank you for that.
Well, thank you.
Yeah. Anyone else want to comment on anything specifically that Karen had? Over here.
Hi, thank you. Karen, hi, I'm Carol Thomas from Casey Care Health Center. I always have my ears perked up when we talk about, of course, diversity in the workplace, regardless of the role, but in particular in nursing, because historically, especially for people of color, nursing has been kind of one of those fail-safe careers that regardless of the time, nurses have been, people of color have been able to pursue careers in nursing. So what I would like to talk about or get some input about is how do we in today's environment continue to promote nursing to people of color? And I don't just mean African-American people, I mean our Latino population, our Asian Americans, our Native Americans, because if you look across the continuum of care, you do not still see a lot of individuals who are pursuing that career. And so I want to know if there are studies or programs that look at the early introduction of people of a diverse background to the career of nursing and healthcare. As a matter of fact, many years ago, and I don't know if it was that many years ago, but here in Kansas City, in the Kansas City School District, they kind of had some introductory health programs to introduce young people to healthcare careers, and they did spend some time trying to introduce folks into nursing. And I've been a nurse for a long time. I haven't really seen a major impact, a major recruitment or folks entering into this as a field, as a career. So I'd like to hear some feedback about what, if there are studies out there, or if there are programs or plans to try to focus, because all of us are, time's not going backwards for us. And pretty soon we'll need to pass the torch to somebody. But I say all the time, I worry about who am I gonna pass the torch to? So I'd like to hear something about that. Thank you.
Karen, do you have any response to that?
Just a couple things and let others comment. One is we actually have done boot camps now for a couple of years for high school students in the summer, nursing boot camp, and we've actually been able to do it virtually, and it's been very successful. And I think the real issue is to have people teaching that are diverse, number one, and men are a huge opportunity for diversity in nursing that we still haven't cracked yet. But But I think when I mentioned the holistic admissions approach, I think that is the number one key, because there are people interested, but they can't get in. They don't have a 3.8 or a 3.9, not because they're not smart and capable, but they haven't had the same life experiences, resources, and advantages many of their white peers have had. So I really think, and I talk about this frequently when I'm with other leaders in nursing education, we have got to just it really codify that holistic process is the way we do this. And it's the way that we actually impact health equity and inequity and a more equitable healthcare system.
You. Any other comments on any of this, Joy? Go ahead.
I'm happy to report that there have been studies about just that, what you described, Carol. And the school districts, multiple school districts in the Kansas City metro area have started programs like the CAPS programs in their high schools. And they have a huge interest in from their junior students, juniors and seniors, huge interest in nursing. I mean, like hundreds of them want to be involved. But unfortunately, what we're seeing is they also are the same kids who say, I want to go to school away from Kansas City, away from mom and dad. So they go to Missouri State, or they go to University of Missouri in Columbia, or they go even farther than KU, really, because again, they want to get far enough away from home, or they think they do. But one thing that will also help, and that we're working toward, and I think maybe most schools are, schools of nursing are working toward, is bringing those programs into middle schools to get them thinking then about, you know, did you know this was available? Did you know that we need men in nursing? This is a profession for everyone. Did you know that, you know, we want people who look like everybody in Kansas City, who've had experiences similar to the people of Kansas City. So getting into the middle schools and then having that pipeline all the way through high school is really what it's going to take.
I just
Go ahead.
one other quick comment I meant to make is that Chamberlain has 13,000 pre-licensure campus-based students right now. 60% of them are diverse, but it requires, because they have other life issues and have not had, you know, they struggle sometimes with the sciences. To do that, you have to provide a different level of support. But what you get is an extraordinary nurse at the end of that 3-year program. And that's where we're not going to be able to make a dent unless we can do it at scale. So across many programs.
You. Maria, go ahead.
Hi there, Karen. Thank you so much for all your comments. I was really intrigued by the concept you were talking about, different models of care, right? And you're right. I've been around for many years, and you know, I've been through those changes as well. I was telling Arams on the way here, my mother was an LPN, and she loved being an LPN. A licensed practical nurse. So she wasn't a registered nurse, but in her time, they worked as a team. You know, there was a nurse, there was an LPN, there was nursing assistants, and it seemed as if everyone took part in caring for that patient. And I loved your conductor example. You know, I think too often we do have young folks getting into nursing, and they're young, and we don't teach them how to conduct. Right? They can play the flute, they can play, but it's hard for them to conduct. And so I'm very intrigued with that, because I do think it's time to change that model to look forward by looking backwards, if you will, and make it better even. So I do think there's a lot of folks that want to get into healthcare. They want to be nurses. I think we need that avenue, that pathway, and Carol, I'm with you. You know, how do we get more people of color to get into this profession? And part of it is, I think we start slow, right? We start slow and we start practical and we start, with the basics and get everybody on that team. So anyways, I like that comment. Those are, I agree with you there.
There are a lot of persons of color who are CNAs. So what could be done? And we want to focus on what, not just our hand wringing this, and it's so awful, it is, but on practical solutions. So what could be done to help some of the CNAs who are persons of color become nurses? And I think some of you have ideas, especially those of you who are deans and presidents of nursing schools. But Angie, go ahead.
Since along that line it also takes our healthcare systems, not just our academic systems, to bring that about. And one could be at Children's Mercy, we started is our Grow Your Own program. And it's bringing those CNAs and giving them opportunities for tuition reimbursement and helping them to be able to get into whichever, if it's a community college program, an ADN program to start, and then to keep going with working on their BSN and so on and so forth. So I think it's going to take the healthcare system as well as the academic system working together to make opportunities. I was also going to follow up on Maria's question to you, Karen, and just ask if when you're talking models, is not only the model of teamwork, but maybe do we look at our shifts, the well-being of the nurses and the shifts we have with 12-hour shifts that can take the toll on them physically. And I don't know if you have an opinion on that as well.
Hi, Angie. Good to see you. I have an opinion, but there's also the reality. And one of the things, unfortunately, that people talk about as a benefit to going into nursing is working 3 12-hour shifts or 2 12s and 2 8s. But we know the research says, at 12 hours the second day, you're not as safe as you are, 6 hours earlier. And so it's a real catch-22. But I also think if we're changing the role, we have the opportunity to change the actual system. And what I mean by that is, I know it's hard right now with where we are to see the long-term potential, but if we're moving to where we're focused more on the continuum of somebody's health and life versus that transaction, you start thinking differently. You don't think of yourself in working shifts. And that's been a struggle that I've had my whole career is, we treat nurses sometimes as commodities. And, we need them when we need them, and we'll pay them extra when we really need them. And then we don't need them, they can stay home for a week. But when you treat professionals like commodities, they begin behaving that way. And so it really sets up a very potentially adversarial relationship when what we really need is everybody practicing at the top of their license as a professional. And it's a struggle in health systems. It's a struggle in nursing education for sure. I do think, back to the earlier point, the biggest thing that people can do to support nurses who are like CNAs, Terry, as you mentioned, is upfront helping them with their tuition. We often do things that are reactive. So if you graduate, we'll give you X, Y, Z and forgive your loan. But that doesn't work for someone who can't even get through the door. There's a health system that in Louisiana that decided they were going to take their employees at different levels in nursing, security, whatever, and their relatives, their family, and pay for their 3-year program upfront. And at the end of their 3 years, when they graduate, they have to stay for 3 as a nurse. And I got to meet some of those first students, and they all said, a year ago, we would never have dreamed that we had the option. One, we don't have a GPA of 3.8, and 2, we didn't have the wherewithal to start the nursing program from a financial perspective. So you're exactly right. We can't do things the way we've done because we're not going to get, it's what Einstein said, doing the same thing over and over again, expecting different results. We're in a whole different place.
On the virtualization, I actually think that's pretty innovative for this time. And it's a way to retain nurses that would normally leave because of the complexity that they deal with every day. And I've seen some pretty creative models of using virtual nurses with bi-directional cameras and helping a novice nurse that's at the bedside or even a CNA of walking them through a process or procedure. And it avoids a lot of the switching that nurses have to do, or the physicians are making rounds. So it breaks up a nurse's process to go round with a doc. Well, they could use a virtual nurse to be in that rounding and then update the nurse. The other model I've seen is that they do 2 days at the bedside, 2 days virtual, or 1 day virtual, 2 days at the bedside. So it gives them some relief, but it also keeps nurses from retiring because they can use the heavy lifting, maybe more than they can handle because of the years of lifting patients, but their brains can still work. And they could mentor and grow novice nurses. And a lot of nurses today are second career nurses. So they're early 30s and, but they look like they've been around in nursing, but they're really new. So those mentoring and coaching on those virtual models is really helpful to keep them there and make them feel safe.
Aarons, is that anything that you have done or would find helpful to you?
It's like
Virtual
interesting.
nursing or telehealth nursing?
Yes, telehealth. I've read about it. Because I'm a critical care nurse, worked in surgical ICU for 14 years. The beauty of nursing is the diversity that the profession brings. The complexity of the patients varies. It varies from unit to unit, from surgical ICU to burn to the BMT. And so it's the application of it as a critical care nurse, I would say it would be very challenging just because the patients that we deal with on a daily basis are just very critical and their condition can change just like that in a second. So you need eyes, you need bodies at the bedside 24/7. Of course, experience will be great to be able to update the team, the doctors, the physicians, the RTs on what's going on. And also, yeah, there's something to be said as well with also families that are also involved with and dealing with the stress, dealing with the pain and the anguish of their loved ones, being sick. I think that having that person, that body to talk to them, to assure them, to comfort them, and guide them through the process is so critical. And I think it will be a challenge to do on a virtual sense, but that's.
So there's different contexts for nursing, and you're really committed to the ICU. So
Correct.
virtual nursing maybe doesn't.
Yeah, it
Same as
would be
practical.
very, yes. There are just some things that I feel would not transition as far as patient care is concerned. And but it still has its place in healthcare without a doubt. And moving forward, hopefully will something that will improve and have ways in the critical care sense.
I'm wondering if we have, John or Cindy, do we have anything in the chat that you'd like to bring forward at this time, or?
So Heather has a question. A large part of the nurse's time is stuck staring at a computer screen and ensuring every detail is documented. The hands-on patient care aspect of nursing has become a backseat to the meet the DOH, JC, et cetera, documentation requirements. If I was 20-something coming into the medical field, I would not be interested in sticking around and would leave to do something else in 2 to 3 years. I've been in nursing over 20 years and remember what it was like for hands-on to be much more focused with documentation being an exception and completed by progress note at the end of the shift. As of 3 years ago, I was staying hours after my PICU shift so I could complete all the mandatory documentation that I didn't do while I was providing much needed hands-on care. What is being done to address this issue in nursing schools to prepare new nurses for this sad reality?
Good question. Any of you have any?
Well, so
Answers?
I would just say it's a sad reality today, and it's got a ways to go. The promise of technology in healthcare, and I'll let my friend and colleague Eva comment on this, but it has just gone so slowly. And because healthcare is so highly regulated, that's made it even more difficult. And there are a lot of factors. But at the end of the day, I don't see us going back to worksheets or spreadsheets where we kept track of everything on a regular basis and in handwriting. I can see where we get to voice recognition. So you're not sitting in a computer, you're talking as you go. And I don't think we're close to that. Eva could probably correct me on that. But it's going to be the reality, and it's going to have to get better. It can't go backward, it has to go forward, and it needs to do that quickly. I will say one of the best things about the pandemic were some of the regulators eased up on certain things as it relates to things that were not productive, things that I think in the past there was no choice around. And I think this is one where regulators have to help us have common sense around what's needed. It's interesting because a lot of people, nurses, like to go on mission trips, and that's because I think they're driven to do, good works. But it also is refreshing when you go on a mission trip. You don't have to document anything unless you think it's important, and that really allows you to use your best and all your time taking care of people, working with them.
Thank you, Karen. It's actually a particular passion of mine. Over the last few years, I've been driven, actually, it's what I worked on my doctorate program on, is what is essential for nursing documentation. And we actually did reduce nursing documentation by 40% because what nurses think they need to document and what they actually need to document are not the same. So one is, it's not the EHR, it's what you put in the EHR for clinicians to document and really evaluate it from a regulatory and patient safety perspective. The other is, as Dr. Cox indicates, our policy setters need to understand what they're requiring does not have an impact. So they may say you need to document this, but there is no evidence that shows documenting it actually did improve a patient's outcome. So a pandemic comes along and we move to emergency documentation or critical documentation, and lo and behold, no one died. It actually had no negative outcome to patients to go back to clinically relevant, urgent documentation. So I think we've got to start pushing back as a profession on what's really clinically relevant to drive a decision, an observation, and an outcome that you're communicating to other care team members that is clinically relevant and not what's relevant to regulatory people and billing companies.
Carol, yeah, I'm wondering what you're thinking about. This.
Okay, so I'm going to flip the script and talk about it on the primary care, on the ambulatory side of the world. So many times people forget that we kind of do the same thing that you're doing on the acute care setting. We still have to document. We still have doctor's orders and referrals and so on and so forth. And yes, we use electronic health record as well. And it is, in many cases, thought of in the same way, a lot of senseless documentation. However, ambulatory care has bitten or has gotten the bug, using tools to help kind of minimize the disdain for the electronic health record by using some of the tools or aids that are out there that we don't typically think about. Now, those of you providers, doctors who are used to having scribes. Scribes are very popular in the ambulatory care setting. And what it does is it allows for a more, I don't want to say rapid or quick, but it does allow for more quick turnaround in the documentation. So we leverage at Casey Care, and I'm going to brag about us because I can. We leverage a lot of the use of scribes by many of the students here from KCU and other of our partner universities and medical schools here in the area, which helps with what? Provider satisfaction, 2, thoroughness of the electronic medical record. And it does provide some relief for clinical staff where it kind of shares the load for the documentation. Now, that doesn't mean that it can be, that we can have a model or practice like that in every arena, but it has afforded us the ability to kind of use new ways to like recruit people to help us, especially in my business. We're a federally qualified health center. So money is at a premium, and paying extra folks to do things, most of the time we can't. So I like to say that yes, the electronic health record can sometimes be maybe burdensome, but I really am going to stick, because Eva used to be my boss, but we won't talk about that. But I will say that the electronic health record has really been of great benefit once we figured out how to use it, how to leverage it, and how not to just make it like one individual user group's problem. Oh, this is just a doctor or provider's problem. Oh, this is the nurse's problem. There are a lot of ways to kind of circumvent the hesitancy in using the record, but you've got to be willing to, do some trial and error to get that. But on the ambulatory side, we don't document nearly as much as you do in the inpatient side, in the acute care side. So, but we do have to document more frequently because, we're subject to people coming and going multiple times. So there's a lot of repetitive documentation. And again, when folks learn how to use what they have and leverage some shortcuts, and I said shortcuts, it can kind of change people's satisfaction with the electronic health record. Trust me, it really is true. I'm not just saying it. I'm, living it. I'm witnessing it, and I'm learning stuff too. And I spent 21 years in the electronic health record business, and I'm learning stuff. So
We're not done with that, but I do want to ask Maria a question because I prompted her on this one. We've been hearing, reading, talking a lot about coping strategies for nurses. And there's been some pushback on that. Not that meditation is bad, or breathing strategies, or all the other sorts of things, journaling, support groups. But is there something else that we should be focusing on for improving the situation that might be more systemic? You're in management.
Yeah, and that's really good. I think you're right. There's a wide variety of strategies each one of us can use individually, and we share what we do. Some of us go out and be with friends, others go out to be alone. But I do want to say that many organizations, our healthcare organization is stepping up and saying, really, this is important. And we've got to put genuine strategies in place that are not just for one group or another, but for every individual in our healthcare system. And so it's really important, I think, that we normalize the ability, if you will, to say, I'm not okay. And I need to reach out, and I need to have someone help me with X, Y, and Z. And that's okay. And we've got people, we've got resources, we've got programs in place that'll help with that. But but we're making it a very obvious and very deliberate plan, if you will, for each one of us in the health system as well. So I'm sure there's other strategies that others, I know Aram's, you're in the same health system. Are you seeing that or benefiting from anything that you hear others doing as well?
And staffing, you need to address staffing too, because that is a repetitive complaint. Is it would be so much better if I wasn't being asked to do more, take care of more patients, more documentation, yes, but take care of more patients. We need more staff.
And I think I probably come from a jaded perspective because we do that. We provide staff, and we'll have our directors put on their scrubs and make rounds.
I know you were doing it
I
on
know.
a holiday weekend,
Yeah, we do.
night shift.
Yeah, we do that.
Yeah.
And that's not just me, it was everybody and leaders and nurses and even administrators. We even had administrators doing that. So you're right, it's staffing. It's people coming to help answer phones, right? That doesn't require a nurse to do that, but somebody from the administrative office coming to answer phones, because that takes time away from the nurse, and that took time away from the nurse during COVID. But we also have a lot of strategies in place, and from using our newly graduated students, if you will, haven't quite gotten to the board, passing boards or taking boards, using them in ways that will grow them, but also help the staff the unit. So,
Angie, go ahead.
Another thing that we've discussed a lot is that we need some meaningful self-care, and it means what the nurses need to do their job well. And in pediatrics, we have a lot of young nurses because they like working with kids. And for them, that means having childcare available close by, that they know that their children are being taken care of while they're there. And so that type of thing, looking at what else do they need, that they're taking care of their families at the same time they're taking care of someone else's family. So I think trying to find out and ask nurses, what is meaningful self-care in addition to pizza on the unit or food or having someone come in and answer the phone. There's some other things I think healthcare can look at.
While you have the microphone, you work for, you're a director in a bioethics center. What is the role of bioethics, people like you and me, in terms of the nursing crisis in America?
I think one of the things is being available, is having ethicists who can help look at help nurses look at the situations they're in. And one of the things is providing a safe, brave, moral space for them to have those discussions. There's many complexities, there's many challenges, and having the facilitation skills to be involved with them, to help them help us understand what we can do to help them. Moral distress is a huge problem, not just for nurses, for all of healthcare workers, especially what we've gone through COVID. Some might even say moral injury, that our military is where they identified that term as what especially our adult nurses saw during COVID. But I think nurses as a whole, there's this moral distress. It's another layer that is working to the suffering. I have to say, and I was talking with a colleague today, is our nurses are weary. They're weary. They're tired. They're physically, they're emotionally tired. And so sometimes systems haven't fixed some of the things that would take away that moral distress. And so if we're there as ethicists to help them see the different perspectives, give them a voice, have their voice to voice those things that they see at the bedside that we need to be doing to fix the moral distress, or to mitigate the moral distress, but also giving that acknowledgement that they've experienced it and they have something to help make it better within the system. And I think that's what we do as ethicists, is oftentimes hopefully we're good listeners, but we let them their voices be raised.
Maria, you do clinical ethics with me, a very valued colleague. And you have any thoughts along the lines of what ethicists might be doing?
we recently had a tough case and we debriefed, and you were on that debrief as well. And I came away after that going, gosh, we really need to focus because that debrief was focused totally on the nurses, but the ethics consult was not. And so somewhere we need to acknowledge that, yes, those nurses were equally distressed, probably even more so because they're there 12-hour long shifts. They dealt with all the events of that situation, you know, but as ethicists, we focused on the ethics case. And so I did come back to Terry and our ethics committee, and I said, we really have to make a deliberate effort to focus in on everybody else who was in that case. And that may have been nurses, it could have been our chaplain. Our chaplain was also very involved in that. Some of the others, social workers, case managers, but we need to, as ethicists, make that deliberate effort.
I have another comment kind of in this area, so let me share it with you. She writes, one of the most wonderful creations our hospital, Children's National, has implemented is Comfort Corner. It's a weekly 2-hour time that a chaplain comes with snacks, tea, aromatherapy, a large screen TV playing soothing scenes and coloring sheets with colored pencils. All the units in our hospitals have come to look forward to this weekly event. I was witness to hardened pediatric intensive care unit nurses who turned their noses up at this and then stopping in one day to grab a snack and ended up staying for 30 minutes. We've had multiple 1 to 2-year nurses say that it was Comfort Corner that helped them not give up and decide to stick around rather than move away from the bedside to do something else. So I think as a kind of a piggyback to that, Terry, you were asking kind of about what ethicists can do. Schwartz rounds was something I think that we experienced over the years. You don't hear much about it anymore, and not to liken it to what Heather's sharing about what they're doing at Children's National. It's not quite the same thing, but that opportunity in Schwartz rounds to kind of bring up those issues, and probably not moral injury, but certainly the difficult, emotionally draining issues that sometimes can be good airing of the grievances, if you will, not to pick up on any TV shows. But what are your thoughts about that? That maybe as bioethicists or as ethics committee members or in hospitals and ethics committees, we can do a better job of providing Schwartz rounds.
Or something like that.
Something like it.
At Children's Mercy, we've begun to do Schwartz rounds, but it's for the whole hospital. And I think one of the things that really came about was it's not just asking those that are at the bedside, because we have others in the hospital, like our security guards are the first people to meet the families as they come in and see how they're, how they can be distressed at that time. And we've actually brought folks in from different positions throughout the hospital to come to Schwartz rounds and tell their perspective on that. It could be the barista down at the coffee shop that actually hears a story from a parent that gives perspective to others. And I think through our ethics committee, we can bring those different perspectives out to say that we are all in this within the healthcare system. Schwartz rounds, John, and everybody can remember, I'm probably not going to give the best, but it is actually where they come and they talk about specific, not cases like we do with case analysis often, but it opens up the discussion about how ethics, what ethical issues, but also what other perspectives have on that case that folks are dealing with at that time. And that's a short and simple. I work in health literacy too, so I like the short and simple type definitions.
Are there any questions or comments from those of you who are actually here in the room? We've got a mic. We can run it. Get up here. This is a provost who can do a lot of things.
Is it on?
Yes.
Okay. This is a question for Karen. I know you mentioned that young nurses, 20-somethings are leaving the nursing profession. Are they in activating their licenses, or what are they doing with their licenses, and what are they doing for income?
So a couple of things. One is a lot of them are keeping their license, but they're finding other roles where they feel like there's more work-life balance and less stress and more control over their work environment. You know, we haven't talked tonight about how many nurses go back to get their become a nurse practitioner, and that is helping with the physician provider shortage, but it's also taking people away from the bedside. So that's one thing. But some are actually just leaving nursing, and you know, I'm not sure what all they are doing, but they just partially, I don't think everybody knows what they're getting into. And I know that we can do a better job in programs and um, in making sure they see the opportunities and they understand how to deal with some of the stresses and what the actual working environment looks like. But and you wonder, will they come back? Did they go are they going to go travel and then they'll come back to a acute care one hospital setting? But the real promise of improving this healthcare nursing crisis would be to get the people who are out of the hospital or out of nursing to come back in.
Would salary increases be the incentive that's necessary? We haven't talked about that yet.
Of course. And I think that nurses have gotten a taste of what that's like. You know, nurses, the job of a nurse today is much different than 20 years ago, and their salaries don't really reflect that. And again, when you pay folks by the hour, they expect to get paid for every single thing. I mean, that's the law. But if you could find ways to assure them a salary, which most hospitals do, but they don't have to. If they all of a sudden, you know, don't have as many elective cases to do, they tell people they can take time off without pay or with a vacation day. So it's kind of trying to shift that role. But, you know, I know it's a burden on hospitals because of the amount of people who are in the labor costs of nursing. But nurses are going to continue, I think, to wield that influence and expect more than they've had in the past, which is why I go back to the conductor role. That's a way you can continue to raise those salaries as appropriate, but also ensure that others are participating in that care under their direction.
Do you want to add to that? You who asked a question.
Well, okay, this does then bring another question that I have. Like internationally, were other countries impacted in a nursing shortage in their country? And then how are they managing that, and how are they managing their salaries in relation to their country? And maybe they have like a national health system, or I can't imagine that they could just easily raise salaries. So what's keeping nurses employed at in other countries and keeping them satisfied with their jobs?
And I guess make that a little more explicit. We're talking about, I said, America's nursing crisis. I mean, United States nursing crisis. You're raising the question of is this a crisis that's international, right?
Correct.
And if so, and maybe it is, maybe it isn't. But if it is, any of you know what's
Yes,
happening elsewhere?
It is. It is
okay.
globally a problem. And in countries with nationalized health systems like the UK, they had for years and years and years and years not had enough nurses in the UK to meet their needs. So they attracted nurses from within the European Union. And then when Brexit was voted to pass in the UK, suddenly they couldn't do that anymore. And they, you know, people went home, to their home countries. So they have been very, very short even before the pandemic. In Canada, they are having similar problems. They don't have enough nurses. They don't have enough nurses in the pipeline, so to speak. And that is in both the UK and in Canada, they have a very differently focused healthcare system than we have. Their healthcare system is not focused on treating illness. It's focused on promoting wellness and prevention. So their staffing needs are different, but they are still feeling the crunch, as are virtually every country. And then the US has a long history of trying to vacuum up nurses from everywhere else because we've been constantly short.
Thank you for answering my questions. I appreciate it.
We're coming up to time, but we might have one more opportunity.
I'm gonna come over here, but I'll ask a question while I'm walking, okay?
Good, good.
So most of us I think in healthcare education or healthcare delivery believe the best healthcare is delivered as a team sport. So I just ask you to quickly react to a statement. I'll admit I read this on Twitter, but it intrigued me, right? All right. So it was posted by a nurse who said, and this will help educate our physicians, okay? So I hope Dr. Stein will use some of this, your reaction to this. But the nurse said, how do I tell my physician colleague to stop referring to me as my nurse? My, right? My nurse, my whatever, okay? I'd like to hear some of your reactions while I go to that question, because I think it will help educate our future physicians, all right? Anybody?
There's a quick way to extinguish that behavior by in front of patients referring to the physician as this is my physician. And I'm not kidding that people have done that, but it's not, I don't think it's done intentionally to be demeaning, but it sure comes off that way.
And that was exactly this person's piece, but it was meaningful to them, so.
I think if we take it back to the patient, it's your doctor and I am your nurse. We are your care team, but we do not belong to the physician and we do not belong to the hospital. We are here for you.
Great, thank you.
Just taking a slightly different direction. And it seems like this is ripe for unionization, that nurses to organize, take better control, the record profits of the insurers, the health systems, I'll say the executives for that matter as well. Just seems the distribution is unconscionable. I'll use that word. Why don't we see more organization to compete for these resources and time and attention?
So does
A quick
somebody at the
response. I can get you a microphone if you want to answer over here. Maria? Karen? Go ahead, Karen.
So I would just say that organizations do an awful lot to make sure that doesn't happen from a risk management avoidance perspective. And I think it obviously is on the increase, not to the extent you might think. But I do think it raises the issue of what is a nursing professional's relationship with a hospital. And I've heard some discussions about governance and not the kind of watered down shared governance that we've talked about for years. And this came from the person, Dr. Tim Porter O'Grady, who developed and coined that 20 plus years ago. But to talk about, is there a way for nursing to govern itself in a similar fashion to physicians so that they're at the table when decisions are being made, important decisions like who's going to get PPE and who's not, and who's going to get staffing and what level and who's not. And I think it could go either direction actually, in terms of how nurses see the ability to have the most effective practice.
Thank you. And unfortunately with that, we're going to have to wrap up. I go away with a pad of practical things that can be done. I have a list of 13. We didn't actually talk about this, but I got this from previous conversation with some of these panelists. Fund nursing education better, raise salaries for nursing educators, provide more creative nursing options such as virtual nursing, telehealth, maintain safe and sane nurse to patient staffing ratios, fix nursing liability threats that were exposed by the Vought case, increase diversity options for persons of color. Don't treat nurses as a commodity and avoid demeaning language as well. Raise nurses' wages and benefits. Provide opportunities like Comfort Corner, I love that, Schwartz rounds, et cetera. Ethics consultation and ethicists can provide opportunities to for nurses to have a voice and to have their voices heard and pay attention to how decisions that are made affect nurses. Provide childcare options, reduce the time and frustration of charting and documentation, or I would add at least provide opportunity for that to happen on shift instead of after shift, use of scribes, perhaps medical students or volunteers. And that's a short list. There are many other things that are being suggested and that could be suggested if we had more time tonight. But we don't. So I want to thank Dr. Cox. Karen, thank you for a stimulating talk that got us started this evening. Very good. And I want to thank our panelists, Maria, Arams, Eva, Angie, Joy, Carol, each of you. Thank you for coming this evening. Your individual and collective experience shared this evening has enriched us all. So we all thank you. I want to say thanks to my Center for Practical Bioethics and KCU colleagues, especially to John Carney, our president CEO, to Dave Sine, my colleague here in bioethics, and to Dr. Ed O'Connor. Thank you for hosting us tonight. KCU did us proud, and we're grateful for that partnership. Jessica Marsh, especially. I don't know where you are if you're in the room here, but Jessica, you're amazing. You were a good hire. Hang on to Jessica. Our KCU AV colleagues, Mike, Shane, Carrie, Joe, thank you so much. We couldn't do this without you. And thank you, Sister Rosemary Flanigan, out in St. Louis. I'm pointing the right direction. Thank you so much for having a birthday, 96 no less, for inspiring younger generations to follow in your footsteps of ethics and education and working for justice in healthcare. Thank you, thank you. Thanks to each of you who support the Center for Practical Bioethics in various ways. You can find us at practicalbioethics.org. To our donors, our grantors, our contractors, our constituents, our board members, our colleagues, thank you. Stay well. Hope to see you again. Good night.